Okay, sir. So we are going live in three, two, one. Please start. We are live.
Okay, thank you. Yeah, good evening, all. Today we are having clinical conversation of prostate cancer CME, and our speaker is Dr. Paulavi Vasu. She is a consultant medical oncologist at Netaji Subhash Cancer Institute. Today she will be presenting a topic on NHSPC. Now the dice is yours.
Yeah. First of all, thank you, Bayer team, for giving me this opportunity. So kindly share the slide.
Sure. Madam, my screen is visible.
Yeah. Yeah, thank you. So today's talk is regarding ARANOT study, where we use darolutamide doublet in metastatic hormone-sensitive prostate cancer. And next slide. So this is my disclosure. Next slide. So first of all, coming to the standard of care for metastatic hormone-sensitive prostate cancer. So we all know that initially we have several options, like we have ADT, means a surgical or the medical castration, like ADT plus androgen receptor inhibitor. We have options of abiraterone. We have chemotherapy option like docetaxel. So we have several trial like Stampede trial where they use doci plus ADT. We have this Titan trial where they use apalutamide plus ADT. We have Peace One trial where they use triplet combination like abiraterone, ADT plus docetaxel. And we have next.
Madam, it is visible. Slides are. Madam, you are on mute.
Some connection issue.
Madam, are we audible?
Yeah, audible.
Okay. My slides are visible.
Yeah.
Oh.
Yeah, thank you. So now we all know that, yeah, next slide. Yeah, so we all know that we have this triplet drug combination, like according to this Aracin trial, where they include darolutamide, ADT plus docetaxel, and which have a very good metastasis, which have a very good result, which demonstrate a favorable efficacy as well as safety. If we compare with ADT plus docetaxel versus ADT plus docetaxel plus darolutamide, now Aeronaut was designed to evaluate like is the darolutamide plus ADT versus only ADT is provide a new treatment option for metastatic hormone sensitive prostate cancer without chemotherapy, like without docetaxel. Next slide. So in Aeronaut, they use ADT plus darolutamide. So it's a randomized double-blind placebo-controlled phase 3 study where they include all metastatic hormone-sensitive prostate cancer patients. ECOG PS was up to 2, and all are histologically proven advanced metastatic hormone-sensitive prostate cancer. And they were randomized into two arms, darolutamide with a dose of 600 mg, BD dose along with ADT, and the next term was on placebo plus ADT. So primary endpoint was to see the overall survival, and the next slide, time to PSA progression. So these are the baseline characteristics. Median age was 70 years, and they include around 32% of Asian population patients, and mostly 52% of patients have ECOG PS0. And see the means disease volume status. They also include low volume disease also, and the country representation across the, yeah. So they also include the low volume disease also, and they include the other area also. Next slide. Yeah. So they include China and, yeah. So now coming to the result, and you see the result that when they compare ADT plus placebo versus ADT plus darolutamide, there was a separation of these two Kaplan-Meier curve, and there was 46% reduction in the risk of radiological progression or death by 46% in the ADT plus darolutamide group. Next slide. So it's a forest plot, it's a subgroup analysis which showed that irrespective of disease volume, whether even it is low volume or high volume disease, whether they have ECOG PS0 or 1, whether they have means Asian patients or non-Asian patients, there was consistent benefit in the darolutamide plus ADT group. Next slide. And which is very important that even if the low volume disease, this Aeronaut trial, they include high volume as well as low volume disease, there was consistent benefit. So this darolutamide plus ADT demonstrated a benefit across all the secondary endpoint like overall survival, time to metastatic CRPC, which is very important, time to PSA progression. So there was consistent benefit. So time to initiation of subsequent therapy, so there was consistent benefit in the darolutamide group. Next slide. So now coming to the darolutamide plus ADT versus ADT plus placebo, time to metastatic CRPC. Again, there was a huge gap with these two Kaplan-Meier curve. And again, we can see that the hazard ratio was very much convincing. It was 0.40. Now coming to quality of life, which is very important. So time to pain progression, again, if we compare with darolutamide plus ADT versus ADT alone, ADT plus placebo, again with a very convincing result, hazard ratio was 0.72. So this combination delay in time to pain progression as well as in the time to metastatic CRPC. Next slide. So now coming to PSA response, which is very important, and with the According to this Aeronaut trial, 63% of the patient in the darolutamide doublet arm attained PSA, very good PSA response. Next slide. Yeah, next slide. Yeah, very good PSA response, and see the higher proportion of the patient achieve undetectable PSA, which is very important, which is less than 0.2 with the darolutamide plus ADT group. If we compare with ADT plus placebo versus darolutamide plus ADT, both, and which is very important, that both in high volume as well as low volume disease, there was consistent benefit. Next slide. So these are all about efficacy, and we know that we have other treatment option, like we have enzalutamide, we have apalutamide, we have abiraterone plus prednisolone, but we don't have any head-to-head comparison. But we know that if we compare the side effect profile, this particular drug is very safe. The only concern is fatigue. The most of the time, patient present with fatigue. And this particular drug is very less drug-to-drug interaction, which is very important if we compare with the other drug. And the other advantage of darolutamide over enzalutamide or apalutamide, we can say that the CNS penetration is less, so there is less chances of CNS side effect. So because of this unique structure, this particular drug has less brain penetration power. So next slide. So these are all about efficacy. Now coming to side effect profile, which is important, as I have already mentioned, that mostly treatment related side effect, like grade 3 side effect, the incidence is very low. And if we compare, the discontinuation rate is very low with the darolutamide arm. And if we compare the darolutamide plus ADT versus placebo plus ADT, we can say that the incidence of side effects is almost same. So median treatment duration was 24.2 months in the darolutamide arm, whereas in the placebo group, it was 17.3 months. So the safety profile of darolutamide in Aeronaut study was independent of PSA response, and it was consistent with the favorable tolerability, as we have already seen in according to the ARAMIS or ARASEN trial. Next slide. So now coming to the side effect, as I have already mentioned, that mostly around 5% of the patient develop fatigue, which is important in the darolutamide group. But see the incidence of fatigue, if we compare with darolutamide plus ADT versus placebo plus ADT, again, we can say the side effect profile is more in the placebo plus ADT group. So there is less chances of inflammation, and almost the adverse events were similar. Next slide. So these are the other side effects like hypertension, like pain. If we compare the darolutamide plus ADT versus placebo plus ADT, we can say that it almost similar. The rate of adverse events are almost similar between these two arms. Next slide. So there was no added side effect in the darolutamide group. So this particular drug is the first and the only androgen receptor inhibitor which demonstrates the clinically and meaningful delay in pain progression as well as in the metastatic CRPC. Next slide. So quality of life is very important. We must say for prostate cancer patient, like as all mostly it affects the elder individual. So if we use a drug which has less drug-to-drug interaction and which is a safe drug, the side effect is favorable so that we can maintain their quality of life. Next slide. So now coming to conclusion, so this darolutamide plus ADT significantly improved the radiologically PFS in patients with metastatic hormone-sensitive prostate cancer. So this particular drug showed a benefit across all the secondary endpoints, and there was a darolutamide was associated with a deep PSA response regardless of baseline PSA. So most of the time they achieve less than 0.2. So undetectable PSA, we can say. So it is the fast and the only androgen receptor inhibitor to demonstrate clinically and delay in pain progression, as well as the
we say that to metastatic CRPC. So quality of life is very important for prostate cancer patient, as I have already mentioned. So if we compare with the other drug like enzalutamide, abiraterone, or apalutamide, the side effects are more. Even if abiraterone, we have to use steroids. So most of the time patients have poor glycemic control. So in that case, I think it's a safe drug. And if we compare with the other drug like apalutamide or enzalutamide versus darolutamide, this particular drug has a unique structural formation so that they have a less vein penetration power. So CNS side effects are less. So overall, we can say it's this particular drug had a favorable safety profile, and darolutamide plus ADT without docetaxel should become an additional standard of care for metastatic hormone-sensitive prostate cancer. Next slide. So now coming to this ARASEC, the new data of darolutamide plus ADT in metastatic hormone-sensitive prostate cancer. Next slide. So again, it's an open label study comparing a prospectively enrolling cohort of men with metastatic hormone sensitive prostate cancer with the ADT alone arm from charted. So mostly they include histologically or cytologically proven adenocarcinoma prostate patient with the ECOG PS up to 2. And it's an open label study. The patient received darolutamide with a dose of 600 mg BD and see the response. Around 223 patients were there and around 393 patients were ADT control arm. And the primary endpoint was to see the PFS. Secondary endpoints were to see the overall survival, time to metastatic CRPC, and also to see the safety profile. Next slide. And see the response. So again, there is a huge gap, huge two difference means a Kaplan-Meier curve are separated. So progression-free survival, which is the primary endpoint, match the population ARASEC meets is the primary endpoint, and it demonstrating the significant improvement in PFS with the darolutamide plus ADT versus only ADT. So see the median follow-up with the ADT plus darolutamide, it was 26.2 months, whereas in the ADT it was 28.3 months. Next slide. So see the overall survival and radiography progression-free survival, which is a secondary endpoint. Again, there was a difference. In the ADT group, it was around 36.8, whereas in the darolutamide plus ADT group, it was 13.8. So again, this combination significantly improved the overall survival as well as if we compare the ADT versus ADT plus darolutamide, again, there was radiological PFS improvement. Again, there was a clear-cut difference of these two Kaplan-Meier curve. Next slide. So now coming to the PSA response, which is very important. Again, we can say that the PSA was less than 0.2 mg per ml. Response rate were more than double in the darolutamide plus ADT group versus only ADT group. So again, there was a very good response if we even where they use this combination darolutamide plus ADT. Next slide. So this ARASEC provides the additional evidence for the darolutamide doublet. The progression-free survival, there was significant improvement. Overall survival, there was significant improvement, 50% reduction in the risk of death. PSA response, which is very important, irrespective of the baseline PSA level, there was a significant improvement. Around, we can say mostly around 70% patient achieve PSA less than 0.2, so undetectable PSA. So aeronaut where they use ADT plus darolutamide, I think it's the standard of care now. And if we are talking about safety profile, as I have already mentioned, that this particular drug has less drug-to-drug interaction, and only the major concern is fatigue, but there is very less incidence. So it's a less discontinuation rate, which is important for any cancer patient. So in the darolutamide plus ADT group, there is less chances of discontinuation. Next slide. Next slide. So I think with this, I conclude my talk. Thank you.
Yeah, thank you, madam, for this wonderful talk. Now